It's 1:30. If you can hear me, I think. I hope.
Speak up.
Speak up. We're going to talk this afternoon about pain management. And this is a very important symptom, and it's the most common patient complaint that comes into the doctor's office. Now, we're not talking about diagnoses, because the most common thing the doctor sees is hypertension and its complications, and diabetes and its complications. But pain is the most common patient complaint. About 75 million American adults experience chronic pain, and about 5 million receive disability compensation for it. So it is a huge problem. And we want to define it, and we'll use as a definition that pain is an unpleasant sensory or emotional experience associated with either actual or potential tissue damage. And pain exerts a tremendous physical and psychological and social toll on the sufferer and the sufferer's family, friends, and healthcare workers. It's a huge problem. Now, we divide pain into acute and chronic. And acute pain is a transient pain in response to a noxious stimulus, which is either injury or a disease. It usually has a readily identified cause, and it dissipates as the exciting stimulus resolves. Acute pain serves as a warning. It alerts the person for need of protection of the part.
That's very true.
If you have pain in a particular portion of your body, you tend to protect that. And it also demands a survival response. Acute pain is accompanied by involuntary autonomic nervous system signs and symptoms. Now, we've talked to you about voluntary nervous system and involuntary nervous system. Voluntary nervous system is move your finger, you move your finger. Involuntary nervous system is your breathing, your heart rate, your blood pressure, your digestive tract, your bladder and bowel function. And when you have an acute pain, and if it's acute enough, it will produce sweating, an increased heart rate, and higher blood pressure, and dilated pupils. And very often it induces fear. And that fear can be anything from mild anxiety to the fear of impending doom. And people who suffer acute, severe heart attacks often have this feeling that I'm going to die. And often it's true. Now, the importance of that is that none of this is ever seen in chronic pain. Personal complaint of pain in a part of their body for 3 months, 6 months, but you don't see any of these other autonomic nervous system signs. Now, tolerance to pain can vary widely from none to over-exaggerated in a particular individual. And it's complicated by the person's mood, their personality, by cultural and ethnic background factors, and the circumstances of the injury, disease, or the disease. And all of these things affect the awareness of pain. Now, the responses to acute pain can diminish with age, but there's an increase in chronic pain with age, more so in women than in men. And more women seek treatment for chronic pain because they have a lower pain threshold and a decreased level of endorphins, which is the substance in your brain, which controls your appreciation of pain. And then again, cultural, emotional, and behavioral influences also affect your description of the pain and how you handle it. Some people, as they get older, have pain, but they complain less about it because of diminishing sensations of pain as you get older, and a more stoic attitude towards pain, as if it were expected that the pain is part of the aging process and is unavoidable. And oftentimes, older people tend to minimize the pain and don't report it to their doctors. Now, in distinction, chronic pain is defined as pain lasting more than 3 months in spite of efforts to relieve it or control it, and with all treatments failing. Time is a wonderful thing about curing pain or injuries that require time to heal that cause pain. And so, unless you treat somebody for a good solid 3 months and you're not getting anywhere, then you can say that this is very likely chronic pain and not acute pain. And they are looked at and handled differently. Now, some physicians say that chronic pain is no longer a symptom, but is now a disease. Chronic pain is poorly localized. It's difficult to quantify. It waxes and wanes for no particular reason. And it's much more difficult to treat or control. And again, as we said, there are no autonomic nervous system manifestations. We often look at chronic pain as a malfunctioning nervous system, a disease process either in the spinal cord or in the brain. A few examples of this might be multiple sclerosis, or brain or spinal cord tumor or abscess, post-concussion problems, and traumatic brain syndrome. And then, of course, people who have meningeal infections often have chronic pain after that. Now, one of the things we have to distinguish is chronic pain caused by cancer, both primary and metastatic, and we distinguish that from non-cancer pain. And cancer pain demands a very aggressive palliative treatment, whereas non-cancer chronic pain is treated much more conservatively and is much more difficult to treat. A seemingly self-limited injury might result in the production of a chronic pain state, sometimes as a result of an incompletely treated acute pain, or a partially healed fracture or injury, or by structural post-injury damage that cannot be repaired or replaced. Now, how do we assess pain? Pain is a subjective symptom. It cannot be measured by any instrument objectively. It depends on a description by the patient, an oral description, a facial expression, body movements like grimacing or screaming or moaning or rolling around. But if the patient can speak, we use a numeric scale from 1 to 10. And I'm sure if you look around your physician's examining room, you'll see some kind of graph on the wall which shows the different degrees of pain from 0 to 10. 0 being none, mild being around the 3, 4 level, moderate being 5, 6 level, severe being 8, 9 level, and excruciating being 10 level. And then for children, and I have it here, yes, for children we have this, which I'm sure you've all seen on the wall as well. None, excruciating, and all they have to do is point. And this is used to, well, you need some way to get the person to say what they're feeling, because, as I said, there is no way of measuring. Now, when there's a lot of characteristics of the patients that go into choosing where they put their finger on this scale, and things that have to be taken into account are the mental status of the patient, their visual perception, their language skills, their ethnic and cultural backgrounds. Some cultures look down upon people who overreact to pain, and there are many others where the pain is exaggerated. And so these things have to be taken into account when you're trying to assess this. And there's also psychosocial factors of anxiety and depression, fatigue and insomnia that often exacerbate the interpretation of the pain. Now, how does the physician evaluate the pain? Well, as I've said to you many times before, the diagnosis is in the history. You have to ask the right questions, and you have to rely upon the patient's basic intelligence to give you some straight answers. And the first thing is, where is the pain? Is the pain focal in a particular place? In your knee, in your shoulder, in your back, in your jaw? Where is it? Is it single or is it multifocal? We have pain in several places. Or is it generalized? Now, I have pain, of course I've said to you before, if you go in and say I have pain all over, the doctor often thinks immediately there's something wrong inside your head. But visceral pain, abdominal pain, is usually deep-seated and generalized and difficult to localize. And I want to use an example of appendicitis. Appendicitis in the old days was a disease of children and old people. And it was not unusual at all in the hospitals where we have grand rounds and we have post-mortem studies to see how many mistakes we're making, that we would miss an acute ruptured appendix in an elderly person. And you often wonder, well, why is this the case? This does not happen now. It used to happen. Now here's a simple drawing of the right side of your colon, which is over here, comes down, and your appendix comes off the tip of this. And that's called the cecum. This is the ascending colon, the cecum, the appendix. And the small bowel comes into the colon at this point here. Now, the appendix nowadays can be visualized easily by ultrasound and by CAT scans. But in the days before these studies were present, the appendix is not always in this place. Sometimes it's up here. And then the pain would be towards your epigastrium, upper abdomen, or around the umbilicus. And sometimes the appendix is down here, sitting on top of your bladder, and you have symptoms like cystitis, bladder infection, and pelvic pain, and pressure, and maybe even frequency. And sometimes it's back here. And when it's back here, you get pain here, because it's under and behind the cecum. And of course, when the surgeon goes in, he just grabs this colon, lifts it up, and finds out where this thing is, and takes it out. Not a difficult procedure at all. But nowadays, with ultrasound and CAT scans in the emergency room, they pick up appendicitis just like that. And the incidence of ruptured appendix and peritonitis is just about nil. But that's just an example of how pain can be not exactly in the place where you think it is. And I've spoken to you before about referred pain. Now, if a person would say, I have chest pain, and make a fist and put it right here, then that's an acute myocardial infarction, that's a heart attack, that's a serious situation. It's easy to decide what to do about that. But the pain from a heart attack can be referred to other different places. It commonly goes down the inside of the left arm. So it's in the chest and down the left arm. That's males. Females altogether are different. Females don't have that kind of symptoms. They may have belly pain, they may have chest pain, they may have back pain, they may have neck or jaw pain, up the neck to the left side of the jaw. I've told you before about Moss Hart, the composer who died on the way to the dentist to get his tooth pulled when he was actually having a heart attack. So that's a common one. Pain under the diaphragm, particularly on the left side, is referred not to the abdomen or to the chest, but to the top of the shoulder. And then when an accident occurs, an automobile accident, something like that, you get a ruptured spleen, then the symptoms are up here. If you had something like a dissecting aortic aneurysm, the pain would be very severe, excruciating down the center of your back. You're right in the thoracic spine area. And that tells the people they better start looking seriously inside to see what's going on. People who have osteoarthritis of the hip and have hip degeneration often do not have pain in the hip. They have pain in the knee. It's referred pain. The problem is up here, but the pain is referred to the knee. Well, if they say my knee hurts and you examine the knee and you don't find anything, then you start thinking, well, maybe it's coming from somewhere else. So it's coming from the hip. And we've said also in the past, in discussing other kind of conditions, about pain in the limbs. Again, the nerves come out of your cervical spine. They form a plexus called the brachial plexus, which comes down underneath your arm. And the nerve divides into three parts. There's the radial nerve, comes down here. The median nerve comes down to these two fingers. And the ulnar nerve comes down to the little finger and this part of this finger. So if you're careful in thinking about where your pain is exactly, rather than saying, my hand hurts, where does your hand hurt? You get a much better chance of figuring out where the source of the pain is, because you can just go back up to the neck. The same thing applies in the leg. There are three different nerves in the leg, and supplies three different parts of your foot. And so if you're careful in your description, you can help the physician in deciding where to look. And then what is the pain like? Well, that's interesting, because I read the comic strips. And today, in the North County Times, my favorite comic strip is Pickles. You know, Opal and Pearl, or Opal, Earl and Opal. And Pickle says to Opal, how would you describe it, Opal? And she says, searing, throbbing, pulsating agony. And he says, I'd say it's like a zombie gnawing your foot off. And the neighbor lady comes in and says, what are you two talking about? And Earl says, what it feels like to step barefoot on a Lego. I would call searing, throbbing, pulsating agony a little exaggeration and misleading. But Earl, these are my favorites. That's today. So what is the pain like? Could be a pressure, could be dull, could be sharp, could be stabbing, burning, shooting, gnawing, associated with numbness. It could be superficially deep. It could be crescendo. Starts off slowly, builds up steam to a high point. How does it start? Acutely or gradually? What about the time aspect? Do you have pain all the time? Do you have pain in the morning when you get up? How is it during the day? Does it get better or worse? Does it come and go? How is it like at night? Why do you think it comes and goes? How does it come and go? If I do this, it gets worse. If I do this, it gets better. All of these things need to be explored by history. What makes it better or worse? Activity, rest, sleep, posture, position, meals, bladder, or bowel function. Does that help it, or does that make it worse? What effect does medication have? It helps some, it helps a lot, doesn't help at all. It gives the doctor an idea about the severity of it when the treatment is attempted. How does pain affect your work, your daily activity, your relationships with people, sleep, appetite, bladder and bowel function. How does the pain affect your mood, sense of well-being, alertness, depressions? All of these things must be taken into account when you're trying to assess a person who has a particular kind of pain. Now, we move to the management of pain, which is what we're supposed to talk about in the first place. The World Health Organization suggests a three-step analgesic ladder. Step 1 for mild pain, rated 1 to 3 on the point scale. Involves the use of non-opioid analgesics. Now, these include the ones that are listed at the top of your page. And we're going to go through these slowly and carefully. Now, aspirin, we all take aspirin, and if you take aspirin for an 81 milligram dose, that is not an analgesic. That is given to you to prevent platelets from clumping together. It's an anti-clotting mechanism. If you're going to take aspirin for pain, you've got to take it in doses of 325 to 1,000 milligrams at a time every 4 to 6 hours with a maximum daily dose of 4,000 milligrams. Now that's where the Bayer aspirin comes into play. Now, if you go to the Walmart, you can buy aspirin of 1,000 pills for about $3. But if you go to buy Bayer aspirin, 100 pills cost you $6, $7, $8. Now, why is that? Well, aspirin is aspirin. But Bayer has a filler in which they put the aspirin, which dissolves immediately. So that if you take 2 Bayer aspirin for pain, it dissolves very quickly in your stomach and is absorbed and may be effective. Whereas if you take the cheap aspirin, the pill may sit in your stomach for a while and may not be absorbed, and you may not get the effect that you want. But aspirin has significant side effects when taken on a chronic basis and in large doses, and that's primarily gastrointestinal bleeding and the development of ulcers and irritation in the stomach. So what is better? The better is acetaminophen, and acetaminophen is Tylenol. And Tylenol is given in doses of 500 to 1,000 milligrams every 4 to 6 hours with a maximum dose of 4,000 milligrams. However, in recent months, there's been recommendations by the National Institutes of Health that the maximum daily dose of Tylenol should be 2,000 milligrams and not 4. And the reason for that is taking Tylenol on a chronic basis can harm your liver and ultimately your kidneys. Now, ibuprofen, naproxen, Celebrex are non-steroidal anti-inflammatory drugs. They're called NSAIDs, non-steroidal anti-inflammatory drugs. And ibuprofen is Motrin, and naproxen is naproxen, and Celebrex is one that you should avoid. The common ones would be Aleve or Motrin, easily bought over the counter, and used in the doses as listed there. Now, if you go from step 1, which is mild pain, to moderate pain, and this can be treated with analgesics in combination with Tylenol or acetaminophen, such as Tylenol with codeine or Tylenol with an NSAID, and these are more effective in combination. 2 plus 2 doesn't equal 4, it equals 5 or 6. And so these are good drugs for moderate pain. For more severe pain, in a rating of 7 to 10 on the 10-point scale, you need morphine or one of its derivatives. And the dose of morphine is 30 to 60 milligrams every 3 to 4 hours. Now, other forms of morphine are meperidine or Demerol, which we do not suggest its use because it requires 300 milligrams instead of 30 to 60, and it is less effective and has more side effects. You go down to the next one, which is dilaudid hydromorphone, And Dilaudid is, you see the dose is 7.5 milligrams. This is probably the most potent morphine derivative that we have, a very good drug, and 7.5 milligrams every 3 to 4 hours. Now, methadone is a drug which you know about because it's what they treat heroin addicts with, because they can pass out the pills, one pill at a time, to the particular person. And this is very useful if done under strict control. The problem with methadone is the dose is to be given every 6 to 8 hours, but the half-life of the drug is 24 to 36 hours. Give a dose in the morning, and that dose is half of it is around for a whole day and a day and a half. And so if you give 20 milligrams and 20 milligrams and 20 milligrams and 20 milligrams, you may end up with a dead patient from respiratory depression. That's why it has to be passed out one pill at a time. And you can't give the person 20 pills and say, take it every 6 to 8 hours. Now, the most common narcotic in use in America today is oxycodone, and that's hydrocodone, or Hycodan. And this is very commonly used, and this is the major drug which is used among the druggies for getting high, and it's the major problem of drug control and law enforcement. But it is a very effective drug when used properly. Now, Tramadol is a newer drug which is out. The Tramadol is very expensive, and in actuality it's no more potent than Tylenol with codeine. The Tramadol is, oftentimes people think the more they pay for something, the better it has to be. That's not always the case. Tramadol is peculiar in that it's in itself, it doesn't do anything. It has to be ingested and then metabolized in the body. And it's the metabolite that's the effective analgesic. And Tramadol is used particularly in people who have neuropathies, diabetic neuropathy and other vascular problems that affect the nerves. And finally, I listed the best drug of all for cancer patients, and that's fentanyl transdermal patches. And that's used in chronic pain, and it's very effective and primarily used in cancer patients who have distant metastases. Now, besides the analgesic medications that we have, there are other things that we can use to try to help to enhance the effect of the analgesics. And these are listed below under adjuvants. We have drugs that can be used for muscle relaxants. A lot of people who have chronic pain are depressed, and for good reason. I think if you had pain day and night, week in and week out, you would ultimately become depressed if you weren't already. Anticonvulsants are used. The one that's particularly is called Gabapentin, and Gabapentin is used in neuropathies again, diabetic neuropathies and other types. Now, nerve blocks and epidural steroid injections. Nerve blocks are often for people with back pain, and the doctor will try, if he can make it, if he can decide exactly where the problem is, he can inject propane, local anesthetic, into the area to numb the nerve, or he can put in epidural cortisone injections, and the cortisone is an anti-inflammatory agent. And I've tried to explain to you in the past that nerves pass through small tunnels or canals, and if the nerve gets swollen, that's what causes the pain. So the steroid injection is anti-inflammatory to cut down on the swelling, which in turn may cut down on the pain for maybe 30, 60, or 90 days. But most of the time, the pain will recur because these nerve blocks and epidural injections are just temporary. Acupuncture has been used. I have no experience with that at all, nor with self-hypnosis. And Physical therapy, and with exercise, stretching, massage, occupational therapy are all good for people with chronic pain. The best thing about treatment of chronic pain is that most people get better. They get better by themselves, but it takes time, and they get impatient, and so they go to a lot of things that maybe they didn't need, and oftentimes this is the reason that surgeries that are attempted don't succeed. An acute injury, like a knee or a shoulder or a finger, will respond to ice originally, and then follow that by heat. Heat increases the circulation to make healing occur quicker and faster and quicker. Often patients with chronic pain are anxious, and tranquilizers are used commonly for that. Now, we're going to go to the front side of that paper. And I'm just going to run down these. You've got them all in front of you. You can read them along with me. But I think these are just short things that gives you some thought as to how we might approach such a problem. An accurate history is essential. All the questions that I ask have to be asked and answered. A calm appraisal of the characteristics of the pain is essential to the diagnosis and prompt treatment. Remember that emotional and psychological factors may influence the perception of pain, and treatment will depend upon the degree of pain as noted on the pain scale. A reasonable dose of analgesics will be given based on your age, body size, and repeated promptly if the initial dose is ineffective, and again if the pain recurs. The doctors who do palliative treatment, the hospice people who treat chronic pain, will use analgesics not on an hourly basis, but on an as-needed basis. Opioids are most effective and may be more effective in smaller doses if combined with other medication. Treatment is based on the patient's perception of pain relief. Patients should be questioned about the current treatment in relation to success or failure of previous pain treatment. And then adjuvant medication, procedures, or techniques should be considered when dealing with neuropathic pain or where adequate doses of opioid drugs have proved ineffective. This is a basic, simple, safe way of thinking about and managing chronic pain. Questions? What?
Yeah, question about methadone.
Methadone.
It's used for pain, and also it's used, we have methadone clinics.
Methadone.
Clinics.
Clinics, yes.
Where people with addiction go
To
to
addiction to heroin.
Yeah, so is methadone addicted?
Yes, yes it is. All of these are addictive.
So what's the
All of these
difference
are
between
addictive.
methadone and then?
Methadone has to be administered one pill at a time in an environment in which the patient is accessible. You can't give methadone and say, come back and see me tomorrow. You have to have it where you can treat them. Usually it's done on an inpatient basis. This is what a lot of the clinics do to try to get people off the drug. It needs to be effective. It's a good drug, but it's a dangerous drug.
Why is it better than heroin?
Well, you know, I don't have heroin listed here. I don't think heroin should be used as an analgesic drug. Jenny?
I'm just beginning to put a couple of things together. I didn't before, but I realized that when I was examining, shortly after I had that fall, my blood pressure had gone up about 45
Points.
points. And would that be caused by the pain from the fall?
Yes, yes it would.
Okay.
The more acute pain, the more you would, the pressure would go. As long as you were aware of it. Of course, if you became unconscious or comatose, you wouldn't have it, that wouldn't occur.
It just puzzled me at the time,
Yeah.
but now it's suddenly gone. So
Yeah, it's an autonomic response, an involuntary response over which you have no control.
Address patches, would you, Doc?
Pardon?
Address patches?
The only patch that I would use is the fentanyl. What kind of patch are you talking
Ben Gay has a patch.
about? Shit.
Is it any good?
I don't have no idea. I've never used Bengay, I don't know anything about it. I don't know. I don't know.
Doesn't that come under the heading of adjuvant?
Yeah, I think that would come under adjuvant treatment. It would also come under,
Johnson and Johnson is touting it.
of course, alternative medicines.
I see.
I put that in the same category as herbs and other kinds of things.
They tried all, doctors, Kaiser doctors tried all different kinds of things for my pain, and none of them did any good, including I had a pain patch which was morphine,
Yeah.
and not even that did much of any good. I suppose, is it possible that some people just don't
Don't respond? Yeah, people are all different, and it would depend upon, basically it would depend upon what is the cause of the pain. And if the pain is that great, then nothing is going to relieve it. But you start off with these and you try one after the other. The response of the patient is not, you can't really tell what the response of the patient is going to be until you try it. Everything is trial and error. And the same thing with the dose. Start off small, you build up high, and you see. But the problem with chronic pain is it's easy to make a person addicted to this stuff. Corey?
I share a common problem with a lot of people. I appear to be allergic to codeine-based drugs. And how can you tell? Is oxycodone, for instance, a codone derivative?
Yeah, it is, but
Codeine derivative.
I would try that, I think.
I would not try it.
No, I wouldn't try it. Now, when you say I'm allergic to codeine.
I'm allergic to codeine. And I said, is oxycodone one of the codeine derivatives?
Yeah. But
So then I can't take it.
well, it depends on what are the symptoms of the so-called allergy.
I throw up
That's a side effect, that's not an allergy.
very shortly thereafter.
It's a side effect.
Okay, I
Gastric-
have a strong side effect to codeine.
Right, gastric irritation and nausea and vomiting are side effects of all these drugs. But that is not allergy.
Okay, all of these are prescription drugs in the United States.
Everyone.
Yeah. Codeine was available without prescription in England, and I used to use that regularly for pain relief, and it's very effective until I started getting sick from it.
Yeah, well, it can make you sick.
So Vicodin and all of those are out.
Yeah.
Yeah.
Vicodin, well, not necessarily. It's worth a try to see. And maybe the nausea and vomiting is because the dose was too high or the dose was too frequent. So that's the reason the doctor says, this is what I think you have, this is what I think you should do, let's try it. So you try, I want to see you in a week, I want to see you in 2 weeks.
Yeah.
And you go back in a week and say, I didn't do a damn thing. Or I did this or did that. And you go from there. And all medications are like that. I don't care if it's antibiotics, anticonvulsants, whatever you're talking about. You start slow, you work it up. Every drug has side effects. Not very many, and most of the time, they're not allergies, although they can be.
You said you wouldn't recommend Celebrex. I wondered why.
The too many side effects, the very serious side effects, and a lot of cardiovascular events, strokes, and heart attacks. And if you take a group of people on Celebrex and a similar group of people not, this group gets much, much more. That's like Vioxx. Vioxx went off the market because Vioxx and Celebrex are like this,
Yeah.
very close. Jim?
Weather, atmospheric pressure has a
Absolutely.
great deal to do with arthritic pain.
Yes, yes it does. Don't ask me why. No explanation for that, except it's a fact.
It's been very bad this,
It should be bad yesterday and today.
Yeah.
We're having a low.
yeah.
Yeah, I don't know why.
Because it's the pressure or the humidity?
No, we think it's a barometric pressure. I don't know.
It can go up, my wife hurts. It can go down, my wife hurts.
Your wife hurts all the time.
She does.
She does.
And she can't take her body doesn't assimilate the drugs the same way everybody else does.
Well, there's another way of administering these, and that's rectally, which isn't used much nowadays, but there are forms of these drugs that can be administered rectally. Avoid the stomach altogether, but who wants to be sticking a suppository up there every 6 hours or so?
Yeah.
But it's a way. That's why the patches are so popular, because you don't have to swallow the pills. Yeah. Jan?
What about bariatric treatment? You know, this talking about atmospheric pressure, there are these bariatric chambers that some people are using. Do they do anything?
No, they don't do a thing. The compression chambers are used principally for drownings and for bends, people who have to be brought up from depths of water and need super oxygen. If you pay $25,000, $50,000 for a tank, that's what we call them, tanks, you want to use your tank. You don't want your tank standing idly by and not carrying its own load. So you put all kinds of stuff into the tank to see if you can help the person, but more likely to see if you can make a profit from the tank. They use this, the only use that I would see, chronic leg ulcers respond to a degree by this treatment. Strokes do not. There's no point in putting a stroke patient in a tank. It isn't going to do anything except make the tank money. There are very limited uses for those tanks, but because they have them and because they have technicians who are on duty every day, they want to use them. So they think up all kinds of ways and reasons of using them.
Do they work for burns?
I don't know if they use them for burns or not. I don't think so, but I don't know for sure. Burns are a specialty unto themselves. And we had a very good unit in the San Fernando Valley, for burns. And it's usually in a county-wide, there'll be one hospital that specializes in burns. It's a very, very difficult, painful undertaking, burns.
You didn't say anything about chiropractors.
No, I didn't say anything about chiropractors. And I'm
They
not,
adjust your spine?
they will not adjust my spine. May adjust your spine, but not mine.
What's your,
I've covered this before. The only place that I can see a chiropractic use is in what is called facet problems. The vertebrae sit on two, like that. And if this one slips, or if you get something in between this facet, then chiropractic adjustment makes sense. Because you've got something squeezed between two bones. And so you open up those bones, the thing pops out, you're better. That's called facet disease. But again, the chiropractor's there, and he's been trained to do all kinds of things, and so he does them. But are they effective? And if they are effective, why are they effective? Are they effective because of what he did? Or are they effective because of what you think he did? I can't answer that question.
Does hot, dry weather improve arthritic stuff?
Supposedly so, yes.
I just feel glorious on a hot, dry day.
I feel glorious, but I've had 2 martinis.
The pains are gone.
as we age,
Yes,
arthritis seems to get worse.
of course. Of course it is. Arthritis, just forget arthritis. Wear and tear. Wear and tear. Bone on bone. No pad, no cartilage in between. It's bone on bone. It's metal on metal. It's bone on metal. It's a shoulder that is shot. Take an x-ray, and instead of a nice round thing like that, it looks like a spear. It's
For some
gone.
people, it's worse
Of
than
course,
other people.
of course. It's worse. It's all a matter of degree. I just hope you guys who are walking 14,000 steps a day don't wear out your bones.
I think there's something to that. Since I've been in the stepping program, I've been hurting.
Well, so the others are doing extremely well.
I know.
Well-
I mean, you just have to find the happy
You
medium.
have to find a happy medium. I think exercise is just like everything else, moderation. You need it, but you don't need 14,000 steps.
People
I
say,
did. Well, they do. They're doing it.
I know.
All the time.
I think about exercise.
Boswell?
Yeah, I have one comment. I think the medical profession are so afraid of people getting addicted when you give them the opiates.
Yes.
And I have an experience one time with my first wife. She had terrible cancer, all that, and the doctor didn't want to give her anything because she's going to get addicted.
No,
That's
that's,
wrong. So what the hell difference does it make?
that's it.
So he finally gave her Brown's mixture and it worked great.
Yeah.
Now, it comes to people who are older, getting close to 90, they're not going to live so much longer.
Careful.
So are we? Yeah, you're not going to live to 120, but I mean, as you get age, why are you so concerned about being addicted when you get so much older? Because it's going to take time before you really get addicted.
Well, what you're saying is true. I made a distinction between chronic pain in cancer patients and chronic pain in non-cancer patients. In cancer patients, you give them whatever it takes to make them comfortable. It doesn't make any difference if they get addicted or not. You keep them comfortable. But if you have a condition like an osteoarthritic thing, you have no idea how long that patient's going to live. And you have no right to cause an additional problem
So when
that might be avoided.
So when you get to be 90, sorry.
We got 4 people being 100 this year.
So but it takes a long time to get addicted, doesn't it?
No, it does not. It does not. Depends on the dose and the frequency and the individual. They're all different. They're all, you can't put everybody in the same box.
Yeah.
In fact, you can't put anybody in the same box. They're all different. Okay, but and none of us can predict. You might say, I'm getting to be 90, I don't think they're going to be there much longer. You have no idea about that. And all I do is look around, look at we got 50 people over 90 and 4 are going to be 100. And I hope I'm one of these. Okay, all right, Jack.
Do we have less resistance to inflammation as we age?
Yes, I think you do. I think the immune system fails like every other system fails, and just like our memory fails, and our bone marrow that makes blood fails, everything goes down. And I think you may be more possibly more. Can't say for sure. Each individual case is different.
If you have inflammation and apply ice, should you always then follow
No.
that with apply?
If you have acute injury, I twisted my ankle and sprained my ankle, put ice on it for maybe 2-3 days, and then put heat on it. The heat helps the circulation to heal, but the ice keeps the swelling from causing more problems. So you do that. Acute things need ice.
And he,
Chronic things, I use heat.
oh, I see.
General, and as a general statement. As a general statement.
Okay.
Okay.
One other question.
One more.
I've seen on television, Phil Mickelson says he has psoriatic arthritis.
Yeah.
What is psoriatic arthritis?
Some people, not everybody, with psoriasis. Now, psoriasis is a thick, scaly, white, reddish patch on the skin,
My dad had.
generally on the knees, on the elbows, in the crease between your two gluteal muscles back there. You can get psoriasis. Some people, very small number, with psoriasis get a terrible kind of arthritis, worse than rheumatoid arthritis. Bad arthritis. But to go on the television with his reputation and his personality and tout this medication is, in my way of thinking, is wrong. And for you to pay, for anybody to pay attention to that is also wrong. You pay attention to what your doctor tells you to do, not what's on the damn television. And I just think that's awful. I cringe every time I see that, and I see it very often. Embro or something like that. Some damn thing.
You know, I was in the health claim business, and we had one man submit a claim for a box, a sun box, with
A tanning box?
it was like a coffin. He'd lay in it like the kids do now. To cure his psoriasis.
Yes, and the sun is very good for psoriasis. And regardless of what part of your body it is, they say get out and lay in the sun, even if you're nude.
We
Psoriasis.
questioned if it was an eligible expense under the terms of the policy.
No, I send them out. Tell them to go out to the beach. There's nude beaches all over.
Not in Chicago.
About your own backyard.
Well, then you got the neighbors.
That's what turned them on, that's okay.
What about medical marijuana?
Medical marijuana is the biggest crookery thing in the world. I said before, you can go to the doctor and say, I want a prescription for medical marijuana, plunk $50 down on the desk, and you got it. And there are doctors who do nothing but write these prescriptions all day long. And then you have medical marijuana, you got 15 places in a geographic area that could be served by one. Why? Because this is all...
Money machine.
yeah, it's just not right. This is not right. The number, and what does medical marijuana actually do? I don't know that they've proved that it really does anything, but what it possibly could do is make a person who has a problem feel better. But it doesn't do anything to the problem at all. It's a symptomatic, would be a symptomatic thing. But most people who go to the medical marijuana dispensaries, when you actually investigate, there isn't anything wrong.
Well, Valium would do that.
Yeah, Valium requires a prescription too, but it doesn't cost you $50 to get it.
Yeah.
No, this is right. The only answer to that is to legalize it.
Take medication you can't take.
I like that. Okay.
Thank you very much. Thank you.